That was the resus part, all right, the unstable patient. Now we'll go through the NTS, the non-technical skill part of this. Because in the background of all of this, we already talked about, there is this wall over here, which I love to talk about, and we'll go into details now about. So, why do I choose a wall? Well, I usually choose a wall when I talk about non-technical skills because I feel like it's my favorite analogy for talking about this. Non-technical skills, if you have a wall where the bricks are your technical skills, like you know how to do a procedure by heart, you know how to treat atrial fibrillation, you know how to do all of these things. That's your like technical skills. But if you don't have any, like, in the bricks on the wall will fall down if you don't have any glue or any mortar in between to like keep them up. So what keeps all your technical skills together and usable in a real life situation, that is your non-technical skills. And there are some things about the non-technical skills that I think are important to just mention right up front. Um, non-technical skills as a concept is ill-defined, I would say. There's everything from soft skills to crowd resource management to non-technical skills to social skills to life skills. They have different names, and they each of these subgroups get at different areas of of non-technical skills. I usually call it all non-technical skills as an umbrella term. And someone in trauma or in aviation might say, "Oh, but crowd resource management was the story. That was the origin of all of this," and it might be true. But several of these things have developed from different areas. So, like soft skills or some of the other like skills are more system-based or more human interacting with technology based, but they all get at the same kind of thing. It's all about um, in short, life skills, how to act in the real world, doing the things that we actually need to do. What kind of skills do we need to do that? Um, um, when we talk about the subheadings within non-technical skills, like leadership or communication and all, they are kind of interconnected, right? It's hard to talk about one without talking about the other. So it's like a Venn diagram. All of them are overlapping in some way. So I'll be repeating myself somewhat when I talk about one and then another because they are overlapping a lot. But I find no other way to do it. um, and sometimes, even though it's a repetition, it's getting at a different area of that non-technical skill. Then it's important to know that subgroups of non-technical skills are very overlapping. Yeah, it's hard to talk about. Yeah. And there's no clear definition of how many there should be or how they should be grouped. So this is my way of just talking about them. There's probably, or there are some studies that would talk about others. There are some areas some studies have tried to like to a once and for all generic what is like the definitive amount of non-technical skills that we can talk about. But yeah, it's hard. So I think it's better to just talk about it and not be too bothered by terminology here. And then it's important to say like knowing one technical skill is good, like knowing communication or leadership is good, but knowing several, they have a synergistic effect. So the more you know, and the deeper your knowledge within each one, the better you are at doing the things that need to be done. You better you are at the logistics part, right? You get better at being getting things done that needs to be done, right? So these are the ones that I have picked out to talk about. As I said, there might be many others that you could talk about, but we'll do these, and we'll start off with decision making. There are some key concepts. I'll do like this. I'll pick them out and I'll just go through. There are some key concepts in decision making. Decision making is about how do we make decisions, and we've been talking about that at length almost for 4 hours now. um, So the only area I haven't touched on in this video, I think, is cognitive biases, and I haven't delved into the halos. But in general, some of the like key concepts that we need to think about here is probabilistic thinking, pretest probability, the test and test characteristics that we talked as we talked about, likelihood ratios, Fagin's normograms, the threshold model as we talked about as well. Fly ahead of the plane is a central concept here as well. Illness scripts we talked about, the time critical and sannolique, or it's likely T plus L, two tables, mental models, and iterative processes when it comes to decision making in the critically ill patients we talked about, two parallel processes in the OABCD, the treat as you go, and the syndromatic treatment. We talked about overdiagnosis and the balance and acceptable miss rates. We talked about cognitive. We haven't talked about cognitive biases, but I've made several videos on that, so you can check those out if you want to. Otherwise, check out Patrick Croskery. His stuff is amazing on this. He's the leading, at least one of the leading like emergency physicians in this area. And we talked about halo and zero warning, opportunity to cost we talked about as well. So these are all things that are key concepts. And some of the key models that we also talked about is like the iterative model. You have your I'll be posting some of the pictures that, like, this is a lightning round, right? This is just going through it so you can and showing where you can like deep dive into it afterwards. But these cues to action, like you have to have these scripts both for the, you have to have illness scripts for time critical and serious conditions. You have to have syndromatic scripts for, or key action, like, or action drills, both for halo scenarios. If this happens, then you do this. But also for zero warning situations where the patient is really bad, hypotensive, right? What do you do? Well, 1-2 IO or something like that, right? You have this, like, is connected to this iterative process. It's like a your syndromatic landscape, and these star signs can sometimes change, but depends on what kind of treatment, like how irreversible is your treatment. You have to, if it's not irreversible, then go for it and try to treat with adrenaline or whatever. We talked about this model, both the Kashira model with thresholds, but also this my probabilistic model with Hickham's dictum, with how the threshold is measured, even though I couldn't remember all of the things there, and also like we talked about all of this. Yeah, you have we talked about the illness scripts. Fagin's nomogram we haven't talked about, but that's in the other lectures. Fly ahead of the plane. This is the cognitive, like this, the model of decision making in emergency medicine, made by Patrick Croskery, inspired by thinking fast and slow and all of that, like system 1 and system 2, dual process model. I've made several videos, as I said, on this. We talked about these mental models that are hugely important, deliberate practice, and becoming an expert in these things, right? You need these mental models to be developed and grown. I have made a decision making and compassionate care playlist where I have a lot of these videos where I talk about cognitive biases, decision making theory, making good decisions, overdiagnosis, how to gather data, compassionate care, all of this halo, right? Check that out if you want to, and especially because the references to the good articles and good foam, free online access medical education on this are there as well. Here's just some of these good references that you could use. Moving on to leadership and followership. So in resus in general, one of the models that are important here is for a leader is the what you call verbal and non-verbal and paraverbal skills, right? Your verbal is how, like, is what you say. Your non-verbal is just as important, is your body language and what you do and so on. And then your paraverbal is your tone, like the way you say it. All of these are really important. And Peter Brindley, and Canadian critical care professor and expert and kind of a controversial figure, but a great guy it seems, who's also made his rounds on podcasts about this in communication, has made this really clear that it's really important paraverbal, verbal, and non-verbal communication as a leader in the resource bay. And sometimes it's said that you have to be like the duck, calm on the surface, like you need a calm room is a good room, but you need to be paddling below. You have to you need to think, and in order to be able to think, you need to cognitive deload. You need to discard things that are not important. You need to be really like knife tight about your who you give your attention to as a leader and how you spend your energy. Sometimes Peter Brindley would say that you should be able to do the resource blindfolded, meaning that your team has to inform you and you have to talk with your team so that you know what is going on. Right? It doesn't mean that you have to talk all the time, but you have to do kind of, and I know Scott Weingart is against doing like a roll call where you say, okay, A, what is the thing? Okay, B, what is the thing? But you rather I think he would like to give each like micro team their own autonomy to say what they need to say, and then he will check in once it's needed, right? So in the resource, leadership and followership goes together. You cannot have one without the other, and both the followers, quote unquote, or the team, and the leader, or you might call it the facilitator if you don't want to have the leader, like the facilitator of the team, which is a role in and of itself, right? Then they have a common responsibility of this like team working. So the leader will take leadership, meaning that he or she will stand on a plateau if needed. he or she will verbally and non-verbally convey that they are the leader. Hey, I am the leader in this team, and it's hard to sometimes do that, and that's why you can call it, okay, if you especially if you're a junior doctor and all of the other team members are senior doctors, you can call it, I'm the facilitator. That I have this from Stimulus podcast about like the zero warning part 2, where they talk about, I'm just the facilitator of this team. I will do everything. So I have the overview, and then you can do your thing. If you want to call it that, then it's fine with me, right? But the problem is if we don't have a clear leader, if you get into a room and one doctor comes in, another, like a cardiac arrest usually, if one doctor comes in, another doctor comes in, and no one knows who's leading, then you get this, what you call a leadership vacuum, right? You will have a team that is not working because everyone is doing kind of their own thing, like a headless chicken. And this creates tension. And if you ask the team members afterwards, then usually it's a high stakes situation where there's no leader, and that's really a bad thing usually. And they don't feel comfortable. So if you're in doubt whether you were a clear leader, then ask the nurses afterwards, was it doing this good or not? Another thing with the leader is they have to create psychological safety. We talked about psychological safety as part of the sign-in. To say like, I'm not perfect. You can convey psychological safety in different ways. It's both something you do before the resuscitation, but also during the resuscitation. You can actively say like, please, I need your help. If I'm missing something, then please speak up. And then they will do that oftentimes, but you need to mean it, right? There has to be a culture of psychological safety for them to do that. And sometimes you need to like specifically tell them, I need to know when, if the blood pressure gets below 80, then I want to know. You can do that as well, like giving them the permission to do that, or to break in. You also need, as a leader, to cognitive deload, because you are massively loaded. If there's something that you have to look up, then make someone else look that up. If you have to put in an IV, or if something has to be done, then it's always another person who has to do it. You have to be hands off the patient, because once you get hands on the patient, then you will be head down. You won't be able to focus anymore. You'll be in a stress cone, or you'll be focused and hyper focusing on what exactly you're doing. All right, that's a problem. And then you're in the situation where you don't have a leader anymore on the team, and then you have the leadership vacuum problem. So you can do, sometimes you do need to do stuff in the team. Maybe you're the most senior or you're the most experienced one to do a certain thing, and then you have to say, well, could someone? Then you have to give the leadership to someone else, or you have to declare to the team, I will be off the leader podium for just a second while I'm checking a thing, and then I'll be back on. But you have to give clear instructions here. An example of this is you can also, it doesn't have to be something that you have to do. Sometimes there is a competence in the team that needs to be in the center, and they have to have the leadership. So sometimes, for instance, during an intubation, you might want to give the leadership to the intubator. So I'll say, hey, anesthesiologist, are you ready to intubate? Good. I will give the leadership now to the anesthesiologist, and the rest of the team, you listen to him or her, and then I will get it back once the intubation is done. And that's one thing you can do as well. It's important both for both the team and the leader needs to develop a shared mental model. If there's psychological safety in the team, then they will ask for the shared mental model once needed. But it's important to know that all team members at all time don't need to know all the things, right? There's a need to know and there's a nice to know, and they only have to do the need to know, especially in high intensity cases. But then once something, like if you have a really high intensity case, then all the micro teams are doing their small things. But sometimes one of the things that one of the micro teams are doing will have a effect on the rest of all the micro teams. So, for instance, if you suddenly have to intubate this patient, if the patient is doing badly and they really have to be intubated now, then this intubation might make it so that the blood pressure will go down and so on. So at that point, you stop being an autonomous micro team, and if you're a good team member, you have to declare to the team leader, I think we need to intubate, and then the team leader has to make the decision whether with the anesthesiologist whether that is now or whether we have time to resuscitate first. But you need to do, in order to do this, you have to create this shared mental model. Okay, team, we have a patient that is we cannot the area is becoming quickly obstructed. We need to do this now. Do an intubation now, meaning that we can't do a resuscitation. I want so that's the priority now. So that's like just a 10 in 10. What do you call it? An update 10 in 10. Like every 10 minutes or every 5 minutes, do a 10-second update. So okay, we were here, now we're here in the resuscitation. Communicating closed loops is important as well. Team member A says something, gives an order, and then team member B says that they received that order, and then team member A confirms that once they've given the drug or whatever that they wanted to give. The team member, the leader, is responsible for flying ahead of the plane. What happens? What's the next step? How long do we need to stay here? Even say to the team, okay, we have 5 minutes until we have to get going. Is everyone okay with that? Or like you have to have that plan, kind of. Avoid rudeness is a really important thing, because there's more and more studies coming out of how detrimental rudeness is in a team. If someone is rude, like cutting you off or being really rude, then it might be just part of the game, right? It might be like when you're playing a game, you're all stressed out, and that might be just that. But if it's a pattern, then you have to talk with that patient, that person afterwards, and that's unacceptable, right? Because it's just detrimental for performance in the team. And there are several ways of handling this, and you can go into the rudeness literature for checking that out. But just try to avoid rudeness and say sorry if tempers get too high at certain points. One way to avoid it is also to don't go into tribalism. Don't say, "Oh, these stupid anesthesiologists or these stupid surgeons." It's not about them. It's about the patient, right? We're all trying from our own way to do the best, right? So it's about mindset, and it's about trying to trying to not be a dick, kind of. And so sometimes you need to develop what you call a sterile cockpit. Sterile cockpit is a thing that is also something that Peter Brindley talks about in one of his articles, where you have to like, okay, everyone, now it's the time where we have to quiet down because we need total attention. It's usually during intubation or something like that, when it's as quiet as possible, right? That's a sterile cockpit. Everyone is doing their thing in calm. Then the team needs to again do closed loop. They have to, but the thing about the team members is that they have to be proactive, not reactive. So again, one of my examples is every time you do an intubation, you have someone who's intubating, but you also have a team member right beside them, right? And the team member right beside the one who's intubating needs to be proactive, not reactive. They need to be one step ahead of the one intubating to know, okay, what do they need now? What do I have to hand them now? They need to like, and then the one who's intubating needs to communicate where they are, and then they know, okay, then they might need some thyroid pressure right now. Do you need pressure? Do you need a different blade? Do you need a bushi? And so on and so forth, right? So they have to be one step ahead all the time. It's important that the team members don't misuse the psychological safety signals, right? So there is some information that is really important and some information that is not. Like, is it nice to know or is it need to know? You don't want, there's a balance between like giving information to your leader or team leader, but also on the other hand, not cognitively overloading them and giving them relevant information at the right time. That's hard. So a good team member will give information in a tight spot that is need to know, not nice to know. And sometimes you need to do what is called graded assertiveness, and I have a model of this soon. But it's like you start off with just saying maybe we should do this, and then you go on to say we probably should do this, and then you say like in the end you're like do this now. Here it's called PACE, like probe, alert, challenge, and emergency, right? And those are the four steps in graded assertiveness. I'm not saying you should exactly use it like this, but it is like a stepwise approach to how to convey information if the leader is not listening or cannot listening right now. If it's really important information, like the patient is losing their airway, then you need to break in and it's an emergency. Stop. Be like the doc, we talked about it. The sign in and psychological safety, I've talked about that as well. Fly ahead of the plane, and whether you're a parallel team or a serial team, if you're a parallel team, you really need these non-technical skills as we are talking about now to be good, and you need to be a good, well-drilled team and leader. Yeah, and this pace here. Okay, so probe, ask a low-threatening question. Is that warning light meant to be read? That's really probing, right? Point out your concern. Oxygen is at 90 and decreasing. That's just stating it. Challenge. The next step is challenge. I think you're too tired to drive safely. Take a rest. That's really like you're challenging someone, and then you have to stop. Like stop. This is unsafe. It's unsafe to continue. Don't drink and intubate. All right. We talk about now. I fitted him in the picture. Dan Dworkis and his The Emergency Mind podcast and book. Amazing read that goes into all of these things. Take a look if you want to. How to create teams in 10 seconds. This is the second part of the Zero Warning podcast, and it's really great. Name, claim, and aim. This is what is. This is the one that talks about, like, maybe we shouldn't call it yourself a team leader, but you could call yourself a facilitator of the team, or in your mind you could call it that, so you don't seem like an arrogant idiot. Or if you're a junior doctor, you might think, oh, I'm too junior to be a leader of these senior doctors. Then you can call yourself a facilitator. Might help reframing it like that. Cliff Reed's Making Things Happen is another legendary SMAC lecture where he talks about how to, amongst other, how to persuade your colleagues to, like consultants, to take patients or to do things. And I'm not sure I buy into the persuasion part, but there's a lot of other things that are really good in this. I think the persuasion part goes in, like, it's like borderline tribalism, and usually the persuasion says that you know better than your consultant and or the anesthesiologist or whoever. I think it's better to just take it as a team member thing, but I might have misunderstood his Cliff Reed's what he's trying to convey here. I've heard this concept both in his lectures, but also when I've spoken with him, and it seems like I don't think I'm. Yeah, you can make up your own mind about that, but it's a great lecture nonetheless, and he's talked about this on the MCRIT podcast as well. And then, of course, Rebellion. I've already talked about this amazing lecture, which you should check out if you haven't already. Specifically for team leaders, Scott Weingart has been on Dan Dworkis' podcast and talked about this. And there's also the Critical Care Now, and also his own MCRIT, where he's talked about the labors of Hercules, or the labors of the trauma team leader, where you can go into more and more details about how to be a team leader if you want to do that. And then from St. Imlans, there was this great one from Ian Beatzel, who's a very humble guy, I think, and who from time to time gives these great nuggets of gold. And this is one of them: how to be a team leader in a trauma team, how to do a script in your head to be your leader, play the role. Especially if you're kind of an introvert person, you might not be comfortable with big teams, but you can train yourself to be a actor. To fake it till you make it, kind of, because if you have the scripts in your head, you know what to say. Then you're not cognitively loaded for what you have to say. Then you can just do what you need to do. Great tips. Check out these if you want to become a better leader in the resource bay. But leadership, and now we're talking mainly leadership, is also a non-clinical thing, in between cases, right? It's both a non-clinical thing where you're a administrative leader, but also a leader of your residents as a specialist, or a leader of your introduction doctors as a resident. Like, we're all leaders in some sort of way in emergency medicine, and there are some key concepts that are important here. As a leader, we should probably, like, this is my take. I know leadership is a huge topic. I haven't read nearly enough books on this to be any kind of expert on it. This is my take, and I'll point you to the literature that, amongst other, Cliff Reed and some other leaders in emergency medicine have pointed at. But there's much, like, this is like, there's as many leaders as there is leader models, right? So, but I think some of the key takeaways from this are what I think here. But yeah, caveats for this could be very subjective. Leaders should facilitate instead of micromanage. I think the leader is not the one riding into the battlefield with the flag, and they might be sometimes, but mainly the leader is someone who has a team that he or she makes work better. He or she is a catalyst in the team, so that they are autonomous to make what decisions they need to make, and they have the tools to do so and to work. That's what a leader does. I read Daniel Coyle's book, Culture Code, where he talks about these three concepts: the belonging, which is essential. Make, like, the team or the leader needs to make the team members feel that they belong to the team. You can do that by, for instance, doing appreciation feedback. We'll talk about what that is, and you have to do for each coaching feedback you do, you have to do 5 times more appreciation feedback, and that means that you have to listen and see what people are doing, because like non-specific appreciation feedback is okay, but specific appreciation feedback is really good. Like, you did that was really good. That's good appreciation feedback. And then reward good behavior maybe especially instead of like with children, right? Maybe especially instead of punishing bad behavior. Then point number 2 is you have to create psychological safety or vulnerability loops and feedback culture, meaning that there has to be like this learn not blame kind of culture. If someone makes a mistake, then you have to not think that the person making the mistake is horrible and a bad doctor. You need to think of, why did this great doctor make a mistake? What kind of system problems was there? And then this is the entire discussion about how do we become better. Is there a safe environment to talk about mistakes? And could we how do we define mistakes that we talked about in part 1, like good decision, bad outcome, or bad outcome, good decision, and so on. And vulnerability loops is kind of part of this psychological safety thing. Like, if I, as a leader, as a senior person, tell my team when I'm doing a case review, I made a mistake here, and I want to talk you through the case and see how you would do, then that's an incredibly strong signal. That's part A of the vulnerability loop, right? You're sending out a signal saying that it's okay to be vulnerable, and if your team is picking up on that, that's a part B of it. Then they will get it back and say, oh, okay, it's okay. And then they might say, oh, I've made similar mistakes. And if then you have a loop, vulnerability loop. And then if you have these loops, then it makes for a more safe work environment, and it makes for a place where you can grow, because you're not afraid of talking about your mistakes and learning from them, right? And this is so essential in all cultures to be able to do this. We'll talk about feedback and all that later, but that's the essence of that. And then you have to have clear goals according to Cole. Most of what we do is complex, right? And if you're working in micro teams, semi-autonomous or almost 100% autonomous, then you have to have agency to actually, you have to have autonomy to actually perform what you need to perform. Your leader has to trust you, but it's sometimes so you cannot like get an algorithm of what to actually do, because oftentimes these decisions are complex. You don't know what you cannot foresee what you have to do actually, and therefore you need to have some principles that you need to know, like your organization's principles, and they have to be like quite clearly spoken out, and quite like it could even be almost cheesy, but it's like, then okay, it's when you come to a situation where maybe this will cost a lot of money and it's a complex decision, I can't ask anyone about it, should I do it or not? Then if your priority is the patient before money, then yes, I should do it. So that's kind of like, okay, I am in a situation where I have to make a decision. What are the values that my values and the organization's values? What do my clinics stand behind? And then when you have these clear goals, then you kind of know in these situations what to do. So those are like Daniel Coyle's 3 feedbacks as I understood them. Then besides those things, I think it's important to be a role model. It's important in all aspects to know, like, when you're walking around the emergency department, everyone is looking at you. It's like just like when you have, like, I have children, and when you're raising children, you're a role model all the time. So you can't like try to think about how you, or reflect about how you talk about patients with your colleagues. For instance, the demented patients in bed A or bed 87, like. We have to do that kind of language. That's okay, but don't be demeaning. think about like more than once or more than twice, more than maybe 50 times actually, I've had patients come up to me or friends come up to me afterwards and say, "Hey, thank you for treating my grandmother or my friend or my colleague." Several times I didn't know, but and how would you and how would you feel if your brother or your sister was the one who was being treated, right? I think it's important to see the humanity in all of it, and this compassion, the care is really important. And it's not, it might sound cheesy, but I think it's genuine. And you try to, I think it's important to try to like find this genuine place when going into the clinic. And then if you get off track, then say sorry if you did something wrong, right? That's also part of being a role model. Being a role model is also creating these vulnerability loops. Being a role model as an specialist is talking with your residents after shifts to check in if they're okay, seeing that they have someone to talk to if they need so, they have your number, or you can do it in different ways. But I think we have a responsibility and a role model, and if more people are doing this, then you create a culture of learning and growing and acceptance and more secure and psychological safe work environment. And you don't have to be an administrative leader to be these things. You need to be you just need to be yourself and clinical, right? Then you have your learn not blame. We talked about that, like when someone makes a mistake, then see the context, do shadowboxing kind of perspective case review of the thing, and then see where you can learn something. And most of the time, usually it's a good decision or it's a systematic failure. Sometimes you can learn something, and that's okay. We all have to learn. Then 90-10 rule of stoicism, how we think about what happens versus what so this is also a podcast in and of itself, stoicism, but the thing is, I guess we need to think about that things that happen to us are not it's not what happens to us, but how we think about what happens to us, how we frame what happens to us, right? And that's also part of being a role model, how to like go through some things and like how to react to some things, like how to have integrity to carry some of the things. You shouldn't put up with everything, but you should also like sometimes you need to like, okay, this is not a big deal. We have to move through. All right, pick your battles and so on. Extreme ownership is just like you need to own your decisions. It's from Jocko Willink. You can check out his massive podcasts; they're great, most of them. And we have to listen more than we talk. And if you're administrative leader, you're paid to make difficult, unpopular decisions. Otherwise you wouldn't be needed as a leader, right? But if you have integrity, the team will usually follow you. So these unpopular decisions are usually, they're unpopular, right? Cutting back or doing stuff that no one wants, right? That's why you're the leader. But if you have integrity, if the group knows that you're with them, then they know there was a reason why you had to do those things, right? I've talked about a lot of these things in this inaptly named probabilistic neurology for the emergency physician, part 2. In here, I talked a lot about leadership and all of these things, and a lot about there's just non-technical skills actually, so you can check that out. Here are some of the books, especially the Culture Code from Daniel Coyle, Jocko Willink, his book Extreme Ownership. I haven't actually read that much of it, but the podcast I've listened to a lot. Sankt Emlyn's Thanks for the Feedback. We'll go into feedback theory in a while. Chris Hadfield's Astronaut Guide to Life on Earth, and EM Case's Leadership podcasts. They have EM Quick Hits, like going through all of these. For instance, Tinsanelli, but also others. And also everything with Howard Ovens. His Waiting to Be Seen WTBS blog on EM Cases is amazing. You have Stimulus podcasts here. Were one of the best leadership podcasts I've ever heard. Is here, this one. It's this one. And then Jeffrey Braithwaite more about the administrative part and complexity theory and all. We'll go through that in a little bit. Well-being. So in 2020, I was part of a group who made this patientsikret arbejdsforhold i akutafdelingerne when I was a member of DASEM, Danish, when I was a board member of DASEM, Danish Society of Emergency Medicine. And we made a few recommendations about well-being and patient-safe work environment, because we thought that, nobody cares about whether there's well-being for doctors. We are highly educated, and we are doing well as a group compared to many other groups in the society. So I get that, and that's why we kind of like that's why we took the patient perspective on this. But we talked about well-being, but we took the patient perspective because the central part here was, if the patient, if the doctor is not doing well, then the patient is not doing well. So for patients to be doing well, we need the doctors to be doing well, right? That's the kind of the thing, and I stand by that. I think that's an important key thing, right? And I think it's a right for anyone who works anywhere to have as good a work environment as possible. Truck drivers, doctors, nurses, teachers, anyone, workers of different kinds. Of course, there has to be safe and has to be bearable. Otherwise, oftentimes, if they can, they will just move as well. So sometimes it's about people not being cut out for a job, and that's of course something you have to find within yourself, whether your family situation and your skill set and so on, and the amount of work that you have to put into something is something that you is willing to do for the rest of your life, for a period of your life, to actually do it. And it might not be. You have something called survivor bias, right? So and in really tough work environments, you have this survivor bias where people talking about or healthy worker bias is called, right? So the ones who actually are working and who have stayed there for a long while, they have some special features. And they, if you ask them, they don't have any family, they don't have any wives anymore, they don't have any, because they have all of their life is centered around this. You might find these things sometimes, it might be a stereotypical thing, but I must say, my experience sometimes with these groups has confirmed that stereotype. Some pre-hospital care doctors, some helicopter persons, right? Some the job is around the clock and it's strange hours and it's intense, and all of these things can be a mix for disastrous well-being, right? Outside of your job. As a long introduction to well-being, but you can check out this entire thing. There are other societies have made something similar. The ASEP guide to investing in yourself, the EMRA, which is the ASEP's junior group, wellness guide. The wellness compendium is an iBook from Arkham, I think, and then they have this Power thing as well from Arkham, the Royal College of Emergency Medicine, and then St. Emlyn's has this recitation guide to health and well-being. So there's lots and lots of topics here, and I'm no expert in these things, but I think it's important to at least talk about these things as well. I'll just give you some key concepts, right? So I mean, a lot of these are just really basic, but it's eat healthy. And what is healthy? I mean, it's vegetables. It's it's very basic, new sciencey and TikToky. You can get into a lot of rabbit holes when it comes to food and nutrition theory and so on. And if you talk about if you talk with someone we look at lectures from Ioannidis, like John Ioannidis, and his look on especially the literature of food literature, it's just so it's one of the reasons why he has this called Janus phenomenon. And the one day you can you can make your data what it has to be. Like one day it's this causes cancer, the other day it doesn't, right? Like I think if you have consistency in your meals, if you eat vegetables and some protein, right? And depending on how much you work out and so on, maybe more protein. If you not too many ultra processed foods and so on. I mean, it's quite basic, right? The problem is beyond like these basic things, it's really hard to make strong recommendations, and that's what a lot of the TikTokers of the world. I might be one of those as well with these podcasts, but they have to like go into these rabbit holes to like really sell themselves on small nuances in dieting to say like this is the new gold standard. And yeah, I mean, not as a general rule. So if you have your basics in eating correct, then usually that's all right. Then sleep. There's this book that there's EM Cases has a pre-gaming podcast, and they have a sleep podcast now as well. And I can't remember the book's name, but there's the Mastering Intensive Care podcast is great at talking about well-being and well-being as a critical care doctor, and they often bring up sleep as one of them a really important thing. I think it's important to know that sleep has like it's both when you like it's both your sleep in inertia and like the amount of sleep you get, but also like again, sorry, I'm no expert in this. Check out the podcasts, but the amount of sleep is not the only part. It's also when you wake up during the days and your consistency in it, right? And your Zeitgebners, you're getting light and getting training and so on. But sleep is important, but strictly like needing exactly 8 hours of sleep every day, otherwise you can't work. And I don't buy into that. You can work if all of the other things in your wellness is okay, but your sleep is one of the like really important things. Move your body. How you move it, in general, like you need to get your pulse up, right? I think it's important to have both aerobic and anaerobic. Oftentimes anaerobic will incorporate aerobic, but I mean, depends. I've been on both ends of that spectrum, and I mean, again, lots of influencers who wants to pull you in one way or the other. I think it's important to have some kind of consistency here, to have like like when to you can plan out your week to see like this time slot I have for training, and you have to prioritize it and do it, right? And maybe not think too much about it, and maybe not have too many goals either about it. Just like maintenance is okay. Anything is better than nothing. All right, and then you can go from there. Like if you're and you need to be able to like it, get someone with you to do it, right? So that you have a partner in crime, so to speak, in the training sessions. Yeah, there's lots of different specific habits that can go along with that, and depends on what your goals are and so on. But moving in some way is important, right? And not only training maybe, but also maybe doing not an exercise things like not being sedentary all the time, but also getting out, biking, moving, taking the stairs instead of the elevators, so on. Everything counts. Investing in your future. This is a kind of mindset about, well, also like if you want to achieve some goals, like if you want to lose weight or gain muscle or whatever, then you have to design your eat, sleep, and move your body habits in a way, much in the same way like things don't happen as magic. Like if you're just exposing yourself at a certain point in time, you will not develop beyond that just by exposing. You need to have a plan, and you need to reflect. You have like it's also like deliberate practice again. And in many areas of your life, it's okay to not like to stagnate, because you don't need to be better than just that. It takes a lot of effort to become expert in a field, right? And you can't become expert in everything. So you need to be non-expert in a lot of things, right? Something is good enough, right? and you need to be able to have that kind of balance. But if you want to like what you do, like you're a product of your habits. What you do today is something that, like how you design or like loosely design your day and week. That will create a product that is you after that week, right? So it doesn't happen by magic. You have to actually do it and design it. Mindfulness and gratitude, I think those are really important things. It's part of compassionate care and your mindset in general. Memento mori, I think personally, is really important. Like our concept of death and being reminded of death, and stoicism, and all of these things. I'll show you podcasts afterwards here, but like being reminded that we are mortal and that each day is a gift is really important. If you do that through mindfulness, or if you do that through other ways, it's great, right? But thankfulness and gratefulness and a gratefulness journal could be a good thing at the end of the day, just to remind yourself to be grateful. Because if you're grateful for the small things, then usually life will be easier. A lot of emergency physicians that I've heard in lectures talk about priorities, and it gets much easier, I think, after you have a child to know what your priorities are. My dad usually gives this analogy about a glass. You have a glass. Your life is much like a glass. And you can put big rocks into your glass. Those are like the big things, like what are like family and friends and maybe your job and stuff like that. And then that's important. Then you have your smaller things, like the smaller rocks, which is like maybe working out. That might be a bigger rock for some, or eating, or doing something. Like then you have your very like your sand rocks, like where you live maybe, or what kind of bike you have, or those are not too big important rocks, right? And as long as you know kind of your priorities, the big rocks, the smaller rocks, and like the gravel rocks, then you kind of know, like when someone comes and asks you, could you do this for us? Like, could you do this study for us? Then you kind of know, okay, do I have time for this? It's much easier to say no when you know your priorities. And it's hard especially early in your career. Then it's easier to say yes to a lot of things, because you might not have too many responsibilities. You might not have too many big rocks. But especially after I have got kids, it was much easier. It's like this prioritization with your time is much more valuable than it used to be. So you do only things that you actually like to do, or which create something as a high likelihood ratio of doing something, right? And you hope that your partner has some of the same rocks, right? Some of the big rocks probably we should agree on, then you're golden. You don't have to agree on everything, right? Again, this is my subjective philosophy. Then, as a career, portfolio careers, like working in emergency medicine is tough. Most people cannot do it 100%. And when you do it 100%, usually most societies will recommend that you only do it 70%, so that you get salary for 100%, but only work there 70%. But besides that reduction in time in clinical work, you should also maybe have a side project that you get salary for, right? You have to niche yourself or subspecialize yourself, both in a clinical topic, but maybe also in a non-clinical topic. Like I'm doing podcasts, I do education, I do non-technical skills, I do instruction. I've kind of subspecialized myself, or I'm on a journey to do so at least in education, right? And you might do that in different areas as well, right? So, but it's good to have some kind of niche that you can do outside of the work, that you can get paid for as well, so that you can get hungry for emergency medicine while you're away, and so on, right? I like to have a work wife. I like to have someone. I usually make quite close bonds. Again, this is very subjective, but this is something Sankt Eminence has talked about a lot, having a work wife on your job. Because if you have a work wife, then you can go to a work wife or work husband, then you can go to this person and do cases with them. You can cry on their shoulder if you need to, especially if you don't have someone who is a medical professional at home who might not understand some of the nuances that you need someone like that to understand, to be able to go through. But I'm not saying that someone who's not medical cannot understand some things, but sometimes you need someone who has medical understanding to go through this with you. Deliberate practice to become an expert in some fields is amazing. We'll go through it in a little while. And then you have to have like compassionate care mindset and learn not blame. Well, we all just want to be happy. It's one of like these central tenets in compassionate care or in mindfulness in general. Like everyone just wants to be happy. When someone is being agitated or being, well, quote unquote, a dick, it's nice to like just think about, we all try, everyone tries to be their best self today. They're not going in, most people are going into their job trying to do their best, okay? And we are all on this journey in life trying to make the most of it, trying to be happy. That's what we're trying to do each day, usually doing things that makes us happy and makes the world a better place. And that's my philosophy. Some people who has a different big five personality score, I might see this differently, but that's how I see it, right? And I think that's a central thing. But these are all teachable things. Compassionate care is teachable, right? It's something that can be taught. It's not, no matter what kind of personality you have, it can be taught. So some concepts that you might talk about. This is from, I learned about this from Scott Weingart as well, Ikigai. And he had like, I'm not sure, and he was not sure that he totally translated this correctly, like cultural wise, but in general, it's, you should do, what should you do in life, right? You should do what you love, what you're good at, what the world needs, and what you can be paid for. This, where all these overlap, is Ikigai. This is something that will make you happy if you work with this. Being happy at your workplace is really important. Having good relationships is amazingly important for your health. But also, like when we talk about, like Liz Crow has taken up this point several times, like burnout a couple of years back was a big thing, and we talked about it in our like thing as well. Like, and we talked about it on the podcast, we talked about it in on our blogs as well. And burnout, it's kind of like a one-sided thing. Like you are either burned out or not. You don't talk about like how important work actually is for someone, how positive a thing it can be. It was not balanced by that. It was just, work is hard, and sometimes it could be really hard, and then you're burned out. But actually, on the other side of that coin is like work can be really good for most people. It's somewhere that you can find meaning. It's somewhere you can find friendships, find an interest, find a purpose. So that's also really important. Yeah, check out Liz Crow's stuff on burnout. I think she is the one I know that has hit the nail on the head, good enough, like most in that concept. Think about improvement in tiny gains. Yeah, that was the best I could find on this. I don't know about James Clear. I don't know about this, but the concept of like incremental increase. If you just grow 1% each day, then at some point you will exponentially grow, right, to much more than you were at this point, and it will go quite fast after a while. So just try to be a little better each day. Don't try to like make these huge goals. Just try incremental increases, right? And try to be better. Now we get to the deliberate practice bit, because okay, so this is a book. Please read that if you and please read these like blog posts, and Imcrit has done great interviews with Anders Ericsson before he died. And in general, I've read the book recently again, and it's about like, so let's say that if you want to be a good something like tennis player or something, like, then you need exposure to tennis, right? And exposure will only get you that far. Usually what we do is you begin what you call naive practice. It's like you do play tennis, you try to throw the ball around, you play with the ball for a while with your racket, and then at some point you can play, and if you practice more and more, then you will actually begin to be good at it, right? To a certain level, but then after a while you plateau. You won't get you won't get much better by just keeping exposing yourself, because you're not reflecting, you're not practicing. And this is what we do. Most of the things we like in life this is what we do, like riding a bike, swimming, running. Maybe like we can't be an expert in everything. We can't. It takes effort, right? And there's a stepping stone between this naive practice and deliberate practice called purposeful practice. I won't go into details, but if you want to like know what purposeful practice is, then read the book or the blog in general. But deliberate practice is something specific, right? Deliberate practice is with a specific goal in mind, and the reason why it has to be a specific goal is that we have to have measurable feedback, right? We have to be able to get feedback to know whether we are doing the right thing or not when we're practicing, right? And whether we're reaching that goal. Different deliberate practice has to be challenging and uncomfortable. You have to be outside of your comfort zone, not too long outside of your comfort zone, because then it will be unbearable, but a little outside of your comfort zone. And you have to have an intense focus. This is not fun to do deliberate practice. If you're having fun during the practice, I mean, you can be in flow, but most of the time during deliberate practice, it's not fun. It's intense, and it requires focus, and oftentimes you have to sleep, or like Anders Ericsson talks about violinists who they have to sleep during like midday after they've done their practices during the first part of the day, right? So then so exactly, so rest and recovery, and it's time consuming. You need to, like, people invest entire lives on this, right? And one of the central things is that you will then develop incremental improved mental models, right? You will reflect on what you've been doing, and then you'll develop better and better mental models, and discard the old ones that you had, and then you'll build upon that. And then sometimes you can jump ahead. You can get a head start if you have an expert coach who can give you some of these mental models and show you how this is done. And then you can build on those mental models and get a little bit further quicker. And how do you pick out an expert coach? Well, sometimes you have, like, in certain areas like classical music, there's a very strong pathway to expertise and deliberate practice, right? But in emergency medicine and other areas, it's not so much a clear pathway. Then you have to find who's an expert in emergency medicine. Well, if you ask people like Gary Klein, who's a cognitive psychologist, and Anders Ericsson, they would say like the experts are usually the ones that by their peers are viewed as experts. They're also the ones who has the most well-developed mental models. So I want you to think about someone in your clinic that has these amazing mental models. And they can, like, having an amazing mental model and being able to explain it is two different things. You might have a great clinician with great mental models, but they're not that good at conveying what they actually have in their head. And if you have some of those, then yes, then you might need to do shadow boxing with them. You need to go through the cases with them to see whether they're done good or not. Like, what would you do in this case? And then sometimes you can, through shadow boxing, pick their brain in the case. Oh, you thought of this at this point. Oh, why? How did you do that? And if you want examples of shadowboxing, check out MCRIT's free shadowboxing cases. Importantly, your coach doesn't have to be an expert in the fields themselves. They have to have mental models. Especially in the beginning, you just need a coach who is good enough at your field, but more importantly is a good teacher, right? So who can teach you and keep you interested, right, and keep you motivated for these things. So that's like these are some of the like central tenets of deliberate practice. And if you don't have all of them, so some of them, that's usually what you call purposeful practice, and you can get quite far with those as well. But if you want to, and the thing about deliberate practice, the sky is the limit. There's no way of saying when you are reaching the limit, and you can begin at any age to develop from where you are. So another good model in well-being is the cognitive diamond. Just to mention that lots of things in KBT, in CBT, like cognitive behavioral therapy, should be taught in general. No, like anxiolytic kind of mental practices, knowing what hypervigilance is, knowing like both for you as an individual, but also for your patients, knowing what somatoform symptoms are, like how our emotions and our physical symptoms often are connected. All of these things, and how to like calm down once you're stressed out. Lots of these things. I think psychology has an amazing ability that is untapped, especially and some central, like quite basic things could be taught to the general public and dispersed like that. Some of the good podcasts on this is this mindset playlist from Stimulate podcast. There's like several podcasts going into these things. The Kettlebells for Brains is about memento mori, how we can remember that death is part of our lives, so we can appreciate what we have now. And here's some of the podcasts and wellness compendiums and so on, and this Crow here as well. Mastering Intensive Care with Andrew Davies is really good for general just wellness and talking with physicians how they do that. All right, situational awareness, a topic that I actually haven't gone into yet at all. I think through many of my blogs and podcasts, and the reason why is because it's so overlapping with everything else. Ensley's model of situational awareness is like this. It's about being aware of your environment, and there's several levels. There are 3 levels usually in this model, right? So there's perception of elements in the current situation. Well, you see the patient, how they're looking. You see that they are sweating, maybe. You see that they are looking in a bad way. Or sorry, you can see they're sweating. You can see their pupils are dilated. You might be able to observe certain things. But the level 2 is that you actually comprehend the current situation. Oh, this is a pattern of these data points is a pattern of this actually being shock or a patient in distress. And then you can, okay, the next level is, okay, this patient is in distress. What do I do now then? What can I do to, like, do I have to work up this shocky patient? What do I do then? Like, so that's kind of like the basic Ensley model of situational awareness. EM Cases talked about situational awareness in episode 75 like this. Get information, scan and, like, that's the level 1, scan and search. Be proactive, look for environment and so on. Remain watchful, expect the unexpected and so on. Understand the information and then think ahead. Let's say level 1, 2, and 3, right? Scott Weingart and Gary Klein often talks about seeing what others don't. And that's when you're an expert, you are better at pattern recognition than others. You might notice certain things that others would not notice in a situation because you have a mindset before you go in. You have practiced this before, and you'll notice things that others don't. And that's the level of situational awareness that is achieved once you reach expertise. Level 3 is like flying ahead of the plane again. You need to, all of these things we've gone through. It's like it's adjacent to situational awareness. Lots of links on situational. The reason why I'm jumping ahead in situational awareness is it's very much something to do with expertise development and all the things that we already talked about. Like in and of itself, it's like a byproduct that is developed through being good at the other stuff. So that's why I'm kind of moving on. But if you want to specifically read about it, I think some of these are the best sources for it. Performance under pressure. I've already done a lecture on performance under pressure in my Halo lectures and also in my the part 2 of the neurological lectures that I showed you earlier. I'll show it again. But in general, some of the key concepts is that when we have to perform under pressure, our amount of stress depends on what our resources are and how the perceived demand is. And if there's a mismatch so that the perceived demand is much higher than what our resources are, then we get stressed out, right? But if we think that we have more resources, or we find ourselves capable, then more capable than and more resources than the perceived demand, then it's okay. Then we don't get too stressed, right? So and then all of this is about like, how do I get either more resources or the perceived demand is lower, right? To even out these. You can do what you call cognitive reframing. That might work on both sides. You might reframe this as, oh, this is a catastrophe, but also sometimes it sounds like positive thinking, like kind of, oh, you're just making it positive just to make it positive, spin on things. But it's not that. Reframing is looking at things from a different angle and trying to like, sometimes you overly say negative things for yourself in your head. And if you're trying to reframe it like, oh, this is a problem, okay, if you see maybe you can call it a challenge instead, then it's something that you can work at, right? Sometimes we frame things in a way that makes it more negative than it had to be. And that's like cognitive reframe. That's cognitive reframing. You can reframe it. Stress inoculation is a great concept when we can talk about in visualization drills, where you it's like we just talked a little about cognitive behavioral therapy, like exposure therapy for stress, kind of like you. So if you're stressed out by being in being at heights, right, then you can stress inoculate or vaccinate yourself by incrementally going up to higher heights in a controlled manner, but just outside of your comfort zone, right, until you can actually achieve what you want to achieve. Stress inoculation is usually like, you have to make decisions. One way of thinking about it is, if you have to make a decision in a stressed environment and it's hard to simulate that stressed environment, then you can, next time you are out running or next time you're out doing something really hard, like physically hard, when your heart rate is up, then try at the peak moment to try to remember how to mix adrenaline IV for your anaphylactic patients. then that's stress inoculation, because you're kind of inoculating yourself. You're putting yourself in an environment that is safe, but still simulating the stress that you might feel in the resource bay, and decisions that or doing what you need to do, right? Before and it could also just be stress inoculation. Could also just be practicing, like if you have a lecture coming up, practice your lecture in front of smaller and smaller crowds and bigger until you can do it. Before versus during. It's important that certain things has to be done before. We talked about, like, again, logistics. You have to practice, you have to visualize, you have to know your action drills, you have to do these IFTTs that we talked about. And then that will reduce your stress level during, right, or before, right? You'll be feel more confident then. But during, what you can do once you are in the situation, right? You can do what you call beat the stressful, or breathe, talk, see, and what's the F? I'll come to it. But breathe is like box breathing. And it's not really like, Scott Weingart has gone back on box breathing recently. So it's not box breathing anymore. It's more like in the Stimulus podcast about this. They talk about breathing, having an out breath that is double as long as your in breath, right? So you breathe in for maybe 4 seconds, then you breathe out for 8 seconds. You don't hold in between. Box breathing would be breathing 4 in, hold 4, and breathe out 4, and then hold 4. But it seems like if you want to stimulate your parasympathetic nervous system, then I usually breathe in through your nose 4 seconds and then breathe out through your mouth, like semi-closed mouth, so that like blowing through a small straw for maybe 8 seconds, double as long as your in breath, and without holding in between. According to Scott Weingart, there's research to support now that reduces your parasympathetic tone. And actually, when I first heard about these things, like maybe 10 years ago or so, and when I adapted it to my practice, I usually did that. I didn't do box breathing. I did just that. So for me, it seems like more intuitive to do it like that. But you see what works for you. Talk is about not having these negative, like I can't do it in the situation. It depends on who you are. Scott Weingart usually says that he's not a person who has too much negative talk in his head, which I truly believe. But talk is mainly try to like maybe cognitive reframe, or giving yourself like, I can do this. I've done the training. I've done this before. I've done it similar. I've been in similar situations before. I can do this. That's kind of your positive talking. C is visualization. If you've done your visualization before, then you can pull up that kind of, what steps do I have to do now? And then the F, now I got it, focus. And Scott Weingart has a word that he kind of, like a mantra, kind of gets him into the zone. And he has like adapted this, like every time he has to do something that is hard, then he conditions himself with this word through a long time. He says, and then now when he's in a difficult situation, he'll just say this word to himself, and then he'll be in the zone. I don't know if that works for everyone, but Scott Weingart's word, I think, is smooth. Like slow is smooth, smooth is fast, I think, and that gets him into the zone. All right. A focus word for me, I've never really worked with that too much. I tried, but I've never really managed to get one really. The closest I've gone is like effortless, or from like it should feel effortless if you like. And then I have had some success with that recently, but it is something like these are suggestions. These are not for everyone, but you can check it out. My Halo lecture for references on this, and then what you can do in situations as well as cognitive deloading. What we're trying to do all the time in this is we're trying to left shifting the curve. Here we're talking about, I will show you the Yerkes Dodson curve. We're trying to, like, your stress level is all the way out to the right. It's too high, so you're like just seeing black tunnel vision. What you're trying to do is left shifting the curve. That's why that's a central topic. That's what we're trying to do with all these things. We talked about Halo and deliberate practice are key. Like Halo is one of the hardest, most intense things, right? So you need to be able to perform under pressure there for real. Boldface is like, it's a Scott Weingart term as well, or maybe an airplane term as well, where you have your book with the most important things that needs to be done in a critical situation, where you read it like a manual. That's a boldface. And performance under pressure. If you have your books, you know where to get the knowledge. You don't have to have all your knowledge in your head. You should have practiced it, but a lot of the things you can look up in the situation, right? And then our intentions honorable. Like if you're doing something cool, this is from John Hines. If you're doing something that might be cool, quote unquote, then maybe that's good enough, right? But you should when you're going into a scenario, especially like a Halo scenario, you should also always ask yourself, are your intentions honorable? Are you doing this for the patient, or are you doing this for just to do a cool procedure? You should always do it for your honorable intentions, because if you do that, then you have nothing to be worried about or nothing to be sorry about if it doesn't work, right? But if you're doing it for yourself, then it's a totally different thing. Here are some of the models. This is from Chris Hicks, or this is a model I've made from Chris Hicks. Paper on stress and stress inoculation. This is the Yerkes-Dodson curve, and left shifting the curve. Like when we're out here, we're all really stressed. We need to left shift it, right? So if we're in this, like demands over resource, then we're out here usually, and then we have to use these things that I just talked about to left shift our curve. I talked about this in these two podcasts: Halo and Procedure and Courage in EM, and probabilistic neurology for the emergency physician. Here's some all about Halo and performance under pressure. One of the big, great ones for outside of Dan Dworkis' podcast is First EM, performance under pressure, and this visualization, how to visualize, is a great tool. Mike Lorias and Weingart's Beat the Stressful articles here. Lots of and Chris Hicks's SMAC and also the human factor article are great. That's where I got this demand resources thing from. Okay. Communication. So communication with the patient, I've talked about at length. I'll just go through some of the key concepts. And numbers needed to treat and compassionate care, I'll be talking about that in a little more detail in part 4, but also check out the lecture that I've made about that. Validation, where I've talked about like how to validate the patient. Like once they've told their story, you should validate, oh, that I'm really sorry, that's horrible. Or when you start to when you see the patient, you ask, do you need anything? Like I see your pain. It's painful to be here in the emergency department, waiting 9, 10, 11, 12 hours here on a stretcher. Can I give you something? Can I give you juice, painkillers, water, a blanket? Should I close the door when I leave? That's validation of their pain and trying to help them with it, right? Ask open questions, as we talked about. Let them tell the story and get the story back. We talked about that in part 1. Expectation management, normalization of like it's normal, it's okay to be in the emergency department. Thank you for being here. It's not your fault that you're here. All of these things are important, right? It's all important, like expectation management, also boundaries and de-escalation techniques. I won't go into details with this, but one of the main things here, one of the main mindsets here is that all patients are, if they're aggressive and not on drugs and not psychotic, right? If they're just non-drug related, and not psychosis related, if they're just angry or seems like they're being a dick, usually it's because of an emotional response, right? It's reactive. 95% of the time, it's reactive. And once you get that, it's reactive. Then you can, that's the key, I think, to get into, like, make yourself small, if it's and be between the door and you, or be between the patient and the door, so that you have a free entrance if it goes bad. Have backup if you need so, and then see if they're, and then say, sorry, I can see that you're angry. Could you please ask me? Could you explain why? I'm just trying to understand. And then from that, you can usually kind of understand that, like, it's usually frustration, and you can kind of talk with them about that, and get like de-escalating from there. If they're a drug psychosis, then there's no need of de-escalation. Then it's just give them the meds so that they can fall down, like go down. And the 5% that are not reactive, they are proactive, or they are actively trying to be manipulative. These are the dissocial personality disorders that are trying to manipulate you or hurt you through your words and being angry because they think they can get something from it. These are really rare, but if you find these, usually you'll find it uncomfortable just talking with them. They're usually unreasonable in a different way, and yeah. We talked about answering emotions with logic earlier. I think it's Laura Rock who's made a great Smack podcast on this, and a BMJ article on this. And she takes her things from Vital Talks. They have the acronym NURSE, but you can also have the acronym GIVE that she made. Like I think it's G for get that there's an emotion instead of logic. Like I'm afraid that my chest pain is going to kill me. But you answer with logic. But your troponin is normal. You have to get that. Oh, you said afraid. This is the emotional response. So you have to answer with emotional kind of. So okay, I get that this is an emotion. Then you identify that, then you identify it. Oh, it's anxiety. And then you kind of validate it, and then you explore it. Right? I get that you're anxious. It's okay to be anxious about it, and then explore. That's GIVE. Get it, identify it, validate it, and explore it. It might not entirely be like that, but you can check out Laura Rock's Smack podcast on this. Delivering bad news. I can't remember whether I talked about this or not. I use it all the time. It's called what you use is usually the spikes model or a variant of that. I would say like this: when you're delivering bad news to someone, whether it's a cancer diagnosis or if it's a loved one who's just died of a cardiac arrest, the people who you are talking to don't know, then I would say, first of all, like the first part is all about getting, firstly, identify the person that you need to talk to is the right one, right? Sometimes it's a room of people you need to point out who's the main person to talk with. Other times it's over the phone and you need to like, are you the right person? Are you the mother of this person? Social security number or CPR number, and then they confirm yes. What are you doing right now? Are you driving? Then it's always hard. It's always hard to give these messages while they're driving. Could you pull over? I need to talk with you. And there's always a warning in this, right? But if you so the conversation is usually like this. Once you like establish that the patient is the right one, like the person is the right one that you're talking with, then you use what you call the stair, right? The stairway. You kind of want to catch them up to speed. I usually do it like this. I ask them, "What do you know that your mother or whatever is in the hospital?" And oftentimes they do know, but sometimes they don't. And if they don't, like the further away they are from the reality of the situation, the more you have to build the stair, right? So if they're totally in the blue, totally in the dark, don't know what has happened, they're like, okay, your mother. Then you have to like narrow it from the beginning. Your mother, from what I know, your mother came in from the ambulance service from the elder home because she was she was feeling bad. When she came in, we saw her. She was really in a bad way. And like you're building the steps, but you can't have too many steps because they know what is coming if you're already talking with them about this. So you want to get to the point somewhat quickly, but you also want to balance out. You need to like have them. You have to build it up so that they can understand it from a narrative perspective, from like beginning to end. If they do know a lot of the things, it's like, okay, you saw them last time when you left them with the ambulance. The ambulance crew did this, and then they came into the resus bay. It could also be a cancer diagnosis. Like you came in with this stomach pain. We did this CT scan to see whether it's something important or not. Now I'm here to talk with you about this. Okay, so that's how you do the stair in different like scenarios. The staircase. You're building up information so that you're on the same page. Once you think you're on the same page, you will do a warning. You will say, I have some bad news. what I'm about to tell you is very is bad news, and you pause. You use a lot of pauses here. Once you have a appropriate pause for a second or two or three, you usually feel much longer. Then I'll say, without, then you then you'll deliver the message without any what would you call it, lingo. You'll say it clearly. You're like, if it's a cardiac arrest case, I'm afraid to tell you that your mother is dead. You'll not say has gone to heaven. You will not say any other lingo. You'll like has expired. It's not good enough either. She's dead. That's what you have to say. So so it cannot be misinterpreted. Or if it's a cancer diagnosis, if you're sure, like I usually say, sometimes you're not sure, then I'll say we found something on your CT scan that might be cancer, but we're not sure yet. It might be not benign, but if you are sure, if the description on the CT scan is often like, it depends on how, if it's metastasis all over, and like then you're quite sure. I'm still like, cancer is diagnosed by biopsy, right? So you can never be totally sure before that biopsy, but you can be quite sure, right? So we found something, and we think it's metastatic cancer in your stomach, something like that, right? And then after you have given your message, then you just pause, and you let the patient break the silence. They have to react, right? They will react. If they don't react, then you'll kind of think about whether they have understood what you said, because this is an important message to them, and this is a horrible message to get usually, right? So if they don't they can react with violence, they can react with anger. There's never any wrong way to react, but you have to set the boundaries if they become aggressive, right? One of the harder things is that if they don't react, right, they will break the silence at some point, and I will always try to make them break the silence. It might take 10 or 20 seconds or 30 seconds, because from then on, they will, if they're reacting like severely, then they will not take in anything what you say. So they will show you when they're clear, like when they're ready to ask questions. So they will have to break the silence, right? So, and then the rest of the conversation just is about them asking whatever questions that you need, that they need right now. Oftentimes you'll refer to a later point where there's more certainty, and I usually say there will be a lot of uncertainty in the next upcoming weeks or months if it's a cancer diagnosis. If it's a death of a loved one, then usually it's something, then you have to explain what happened and how and so on, and what's the most likely and what happens next. It's a good idea to have a nurse with you, or someone so you can leave once, like so they can take care of the emotional response after a while, because you have to take care of other things. Not that a nurse doesn't, but you have to think about, you have to have an exit strategy after a while. Okay, so that's the spikes model. Last thing I'll say about that is, if you don't have someone, if you have someone who doesn't react, then, and you're not sure whether they got it, then sometimes it comes up, like, what will I say to my kids, or what will I say to my loved ones? I often say like, just so I'm perfectly made perfectly clear what has happened here. Just so I make sure, I'll make sure that I've conveyed this message properly. Could you please repeat what I just said to you, just in a few sentences? Because that's great in any patient interaction, to do that repeat thing. So is it fair to say that this is like this and this is like this? Yes, but especially here, so that they don't, and then often they will say like, yeah, I have cancer. Okay, well then like, that was just a, and whether they understand the gravity of it or not, that's usually for later but most people will understand that cancer is a bad thing, and something they could die for. All right. Verbal versus non-verbal. We talked about this as well. Your tone is really important as well, and your non-verbal and tone is at least as important as the verbal. Some old studies says this, but I would say by experience is really true. Active listening, using silence, rudeness we talked about, and tribalism and so on. We talked about these things. I talked about this in these, and also in some of the other like probabilistic lectures on communication. This one. Here's some references on rudeness and tribalism and de-escalation. This verbal judo and these EM cases, these are really great for de-escalation. And communication in general and compassionate care, here are some great links. Okay. Feedback, learn not to blame, and deliberate practice. Some key concepts here are so feedback. A lot of the feedback theory I know is from thanks for the feedback and St. Emlyn's feedback courses that I've attended. In general, so my viewpoint is from that. But as I understand it, a lot of the theory about feedback is going that way, and like so deliberate practice, thanks for the feedback, those are usually my like where I have it from, and several podcasts on it. But all right, and courses. So key concepts are ACE. There are 3 kinds of feedback. There's appreciation, coaching, and the evaluation. All kinds of feedback has some overlap. So when you are doing appreciation, you might have some coaching in there as well. But you should try to keep walls between which kind of feedback you're giving. Appreciation has to be specific. Wow, you did that, like you did X, that was really good. It's more powerful than just saying, oh, I loved how you worked today. Coaching is how you get better. It has to be neutral for be as effective as possible. Can be a little bit positive, of course, but negative coaching works as well. It's just hard to hear. If you like, you hit like a girl or an idiot or whatever, like you dumb idiot. if you do it negatively, then you don't have to do it negatively. You can just say do this, because doing coaching feedback is often hard. Like it's hard to hear do this instead of this, unless you are primed for it. You have to be primed for the coaching, right? So a lot of the feedback, and we'll go back to that as well, is it the right time for the feedback? Is it the good time, like when you're giving the feedback? But coaching feedback is and this is where we say like appreciation feedback has to be 5-1. Otherwise, they won't hear the coaching. They will hear the coaching as a hard thing. If you say do this instead of this, if they know they are appreciated, if they know they're doing a good job in other cases, so then they will take in the coaching much easier. Evaluation is something that you do at a much longer time frame. It's a comparison of the one you talking to, or the one getting the feedback, compared to others. That's usually your like the yearly conversations with your boss or whatever. And yeah, there's always a certain amount of evaluation in your coaching. If you have to coach all the time, then if you don't get too much appreciation, that's in evaluation in and of itself, right? So then when you are the receiver, the most important thing here is not the giving of the feedback, it's the receiving of the feedback. And so Richard Wolff is a Beth Israel professor in emergency medicine, and I've been to some of his lectures and talked with him, and he would say that there are 3 things that you're not allowed to be in emergency medicine, or I guess in any workplace. You're not allowed to be lazy, meaning that you should be able to work. You're not allowed to be dumb, meaning that you need to know your theory, you need to know your stuff, and you're not allowed to be arrogant, meaning that you should be able to take feedback. If you're 2 of those 3 things, then you're unable to be, well, you cannot work with you. If you're arrogant and dumb, then you will never learn, right? If you're lazy and arrogant, then you won't take feedback once you say when someone says that to you. An important thing about being this is about all getting feedback is this goes into well-being and growth mindset and incremental increases and so on. But you have to understand your feedback when you're receiving it, right? So if you don't you can get a lot of feedback and you need to be open for it, because the main mindset here is that if only even though the feedback that you're getting is delivered badly by the wrong person at the wrong time in the wrong way, then there might be maybe 1 or 2% that could be right. But right when you get the feedback, you usually have some kind of emotional response, which would be longer or shorter depending on how high stakes there are with that feedback. And then you'll have the emotional response, and then you might be angry at the person or whatever. But once that has settled, then you kind of need to go back to the person after a few seconds or hours or days and see whether is this how I want to understand what you said, right? Because if you don't understand the feedback that you got, then you can work from it, right? You need to try to understand the feedback that you get, and that requires a conversation with the one who gives it, right? What I just talked about, the notion that if there's just 1 or 2% that is right of what that that person is saying, then if you can pick up 1 or 2% every now and then and every here and there, then you can grow very quickly from that, right? That we call spot the right instead of spotting the wrong, which is your emotional response usually. That is wrong because it's the wrong person, it's the wrong time, it's the wrong. But that doesn't mean that it's not right, or that might be 1 or 2%, just 1 or 2%. That's the mind frame, right? There might be 1% of what they said that was something that you could use, because the main thing here is that getting feedback, we are really bad as humans at evaluating our own performance. We need feedback for that, and luckily others are quite good at looking at our performance usually, and giving us feedback, coaching, right? They can see it from another perspective, but we are quite bad. So we have this blind spot bias that we think we are great, the Dunning-Kruger effect, at least in the beginning, right? And once we have someone looking in, then it feels hard to burst that bubble. It's oh, you're not doing that really good. And that could be delivered in different ways, but we need that peer review. We need that feedback from others to actually see ourselves as a mirror to ourselves. And so we are desperately in need of feedback from others, as a basic thing. But we just need to understand it, and we need to try to spot the right mind frame of it. And then we have to this learn, not blame. We talked about the psychological safety and all. We talked about good decisions, bad outcome, and avoid the retrospective score. We talked about that in part 1. We can talk about. We'll talk about in part 4. Individuals are saving medicine instead of is it the system failure, or is it the person that is the failure? Is the bad apple, or is it, we can talk about it in part 4. We talk about feedback culture and vulnerability loop and psychological safety. So we talked about a lot of these things already. I just wanted to show you these. This is the hindsight bias or retroscope. This is my spotting it right, spotting the right thing. Just putting what people say sometimes under a loop and just looking. We talked about this one again. Here are some books that are great. Thanks for the feedback. They also have podcasts, and they're from Harvard. And the Sheila Heen and Dr. Stone have both podcasts and really great videos if you don't want to read the entire book. But I think this is one of the books that is readable and good to read. This as well. Shadowboxing, we talked about feedback is such an important thing. Peer review is such an important thing. I've made videos on this, and especially this one talks about feedback. Here are some of the good literature, especially Sankt Emlens and Simon Colley has some great videos on and podcasts on feedback, because they make this course that goes into all of these things. Sidney Dekker talks about and especially Warul Patari, who's a emergency physician, who has made Sidney Decker's videos of human error and made them into for emergency physicians, how to think about failure. It's a really great one. Yeah, I mean, check these out. Okay, nearing the end of this part 3. I just wanted to, because I've mentioned this so much, and I mentioned all of these blogs and all these books. I just wanted to, just in the end here, to just say, I mean, you don't have to read specifically those books or podcasts that I prefer or that I recommend. It's something that I've researched and studied for a long time, and I've been in this kind of sphere for, well, the best of 10 years and more maybe. And my way is not necessarily your way. Take what you can to be inspired, and find your own way as well. I just wanted to show you some of these, both to show like gratitude to a lot of these podcasts and books and FOAMed content that I've actually consumed and has kind of developed me into what I am today, or has been a big part of it. And I guess also just to show you which ones I really prefer here, especially in this non-technical skill kind of field, because you can learn a lot by listening to these. Be skeptical and go and research yourself if there's something that doesn't really match your worldview, or see what other podcasts think or other FOAMed areas think, because usually they don't necessarily agree, and it creates this quite a great sphere of having an atmosphere of really great content where you can where they can kind of get at each other and debate important topics. So just without further ado, show you some of my favorites in FOAMed. I forgot 2 I can already recall. To begin with, I will say Life in the Fast Lane is really good reference for checking out I mean, content of clinical significance. If you want to, like, it's almost like a Wikipedia kind of, and also for point of care ultrasound cases, it's the greatest. And for reviewing, it's like they have everything. Some of these sites are niche. Life in the Fast Lane is everything. Emergency medicine cases is another, like, probably the best all around, I think, because they both have their Journal Jam, which is like a review thing where they take in Justin Morgenstern and Britt Long and others, like really great people, Ken Milne, to like debate and review topics. But they have their their main cases series, which is free, and it's just like 200 episodes or more at this point. And I think it's 207 maybe. They have these EM cases summits every year or every second year, I think now. And they have ECG cases, which is one of the best resources on the internet to find out, like to test your knowledge in different ECG patterns. You have and it's such a great all round, right? I can't recommend it enough, and it's for Scandinavian viewers or listeners, it's quite okay. I mean, most of their they often refer to the European guidelines, so they're not that American either. So it's really just a great base base layer of knowledge to get that, and then you can check out other stuff as well. MCRIT, and especially I would say more and more IBCC, the Internet Book of Critical Care, is just an amazing reference, right? The Internet Book of Critical Care, I haven't mentioned that much, but it's just amazing. It's, if you want almost any topic in critical care, emergency medicine, and maybe a little bit more upstairs care than downstairs care, then you can find just a gold mine of both podcasts on a specific topic with Josh Farkas, who makes the PulmCrit or IBCC book, but also and he's interviewed by an emergency physician, I think it's Adam Thomas or something like that, and they like, if you want every time you go home after a shift and there is one topic you didn't know, that's my go-to reference usually, IBCC, to just get a quick overview. That's great. MCrit has become a pay site now, but they do have some stuff that is not pay sites, the most important stuff, and my hat off to Scott Weingart for doing that, even though I know many of the bigger foam blogs are moving in that direction for like pay-per-view. He's still keeping some of his content out there, and MCrit is mostly critical care, right? But there's so much ingenuity and so much innovation, and Scott Weingart has made so much like both in the like performance under pressure or the mind of a resuscitationist, and like he's a cultural like inspiration, and has brought forward our field enormously, I'd say. And he's on other podcasts as well, so please listen to him when he speaks about non-clinical topics as well, like on Smack, and yeah, it's just great. First 10 EM is one of my, like, probably outside of emergency medicine cases and IPCC, my favorite blog. Justin Morgenstern is just amazing, and he has this kind of like balance between doing and not doing, which is much what my philosophy is in this field. So I just first in EM, he's evidence based. He shares his mind. He has controversial topics, but I think he usually researches it really well and has really good arguments of like over diagnosis, over medicalization, and so on. Like he compassionate care. Like he seems like an all-around great guy and a great doctor, and he knows his stuff. So yeah, I can't recommend his site enough. Stimulus podcast by Rob Orman, who is in collaboration with Scott Weingart as well. It's for all non-technical skills, like all of these pages have non-technical skills as well, but this one is probably the non-technical skill podcast in emergency medicine. It just has some great content, and there is some fluff in between, but I think he manages to like keep it quite straight, and just really, really good. St. Emlyn's is one of my old favorites as well. They, when it comes to decision making and kind of like Simon Carley with his SMAC lectures and some of his views here, and also like with complexity and crowding, as we'll be talking about in this part 4. Lots of the articles and foam comes from here, and emergency medicine cases. It's just really great, and it's British, so it's more Scandinavian than many of the other podcasts. So yeah, I really, really enjoy that. And SMAC, yeah, SMAC is no more. It was taken over by Coda, and Coda is no more either, I think. But you can still find the old talks from SMAC Dublin and SMAC Germany, and the theory still holds. The thing that they were talking about almost always still holds. So check those out. One I forgot as well, outside of Life in the Fast Lane here, is Mastering Intensive Care by Andrew Davies. It's like also a more wellness kind of blog where he interviews people who's been either medical or non-medical people, like Martin Bromley, and just going through both how their routines are and how they're still healthy, but also like just talking about how to survive in this field. And he's an intensive care doctor, so it's tangential to emergency medicine, right? So just a great one as well. First 10 EM often collaborates with Broomdogs. Casey Parker is like in the same vein as Justin Morgenstern, just on the other side, just in Australia. Just great clinician, it seems, and just all around good doctor and good like decision making. You can learn a lot by listening to his blogs. He's one of the people who's made a probabilistic lecture in SMAC as well. So they always talk probabilistics. Him and Justin Morgenstern is just great. The Skeptic's Guide to Emergency Medicine, Ken Milne. If you want the nerdy part of reviews of studies, but also his it's mainly a evidence-based kind of review of articles in 30 minutes and learning how to do that. But it's also his extras, which is interviews by, for instance, for instance, Jerome Hoffman, who's like this amazing professor of emergency medicine, who's inspiration for most of these blogs as well. Like, so Ken Milne, and also Ken Milne has a YouTube channel, which is amazing as well. First Tenium has as well, and those videos are really great as well. So like, yeah, they have some great videos that condense their philosophy. EM docs, and also what's called ALIEM, and also MRAP are like the more American ones. But I like EM docs the most because it's more like, if you want, it's like Wikipedia like. So where IBCC, MCRIT's IBCC is more maybe upstairs care related, then EM docs is more encyclopedia with downstairs care. Rebel EM has amazing YouTube content, like short form videos for specific topics. He just knows how to make these 6 minutes videos in such a like visually entertaining, and has some great takes on a lot of things. He doesn't make that much content, I think, anymore. But he did do this Rebellion conference where videos are still there as well. It's just great videos from there. Okay, this wouldn't be complete without a book kind of like review, or I'm just saying I love books as well as reading blogs, and as well as listening to blogs. I'm not saying you should. And after I had children, it was definitely a harder thing to read books because I kept falling asleep. But if you have the time, or you can find the time for it, there's amazing resources that can teach you a lot about being a doctor. And some of the ones that helped me along the way are some of these books, like Mastering Communication with Anthony Back, At Vær der hvor du er with Bent Falk, Lost Art of Healing with Bernard Lown, like the Checklist Manifesto by Atul Gawande, The Cognitive Autopsy by Pat Croskery. Some of these books are not for reading in a cozy time in a hammock. Some of them are more case-based or more medical books, or and like not for lay people. Cognitive Autopsy is an amazing book, but not for lay people. And the Communication with Seriously Ill Patients as well. Anthony Back with Vital Talks. It's not for lay people. I haven't read this one yet, but one of my former colleagues and like KBU AT-läkare introduction doctors made this book this year, and it's a topic that I've talked about a lot that she's talking about. So I'm pretty excited to read it soon. Atul Gawande, Being Moral. Gary Klein as well. Like, this is a layman's book for all doctors or all decision makers. Just great. It's the not the opposite, but it's opposed to, I guess, Thinking Fast and Slow, which is more System 2 prone. This is more System 1 prone. And It's All in Your Head by Suzanne O'Sullivan. She makes great books about like the functionality, like a biopsychosocial kind of model in neurological diseases and functional diseases and like somatoform diseases. It's just great for any doctor to know kind of these diseases or illnesses, because they become more and more prominent, and makes you a bit more compassionate about the conditions. Bad Pharma, yeah. About from Ben Goldacre. He's made other books as well about this, like the corruption, or I guess not corruption, but all the major problems with the replication crisis that we have in medicine. Ending Medical Reversal, about also in the same vein, Vinay Prasad and Adam Sifu, talking about when we get things out in the open too quickly, the horse is out of the barn. When you when you do an RCT and you think this drug is great, even though the RCT is not high enough quality or whatever, and then the drug is on the market and it takes 10 years to get back, right? So that's a medical reversal when it shouldn't have been on the market to begin with. So it's just a great book as well, to like in a niche topic. Karolinska, we're going to talk about it in part 4 about all of these amazing all these complex system problems that arise. I think Kampmann Karolinska is a great example. At least in Scandinavia, I found the same thing in Denmark, where whenever you implement something in these complex healthcare systems, it will be a huge problem. And the specific case of Karolinska is specifically interesting because it was made like from the start to finish. It seems like it was such a chaotic project where lots of the cultural things about feedback and psychological safety just went out the window. You had non-experts talking about all of the things that we will talk about in complexity science in part 4 was not. I'm sure lots of people's intentions were good, but it didn't reach out in the outcome. And yeah, a great book about which also won, I think, Gustav Priest, August Priest, which is a great honor here in Sweden. The Focus Manifesto. These are just a flung of books. I have many more, but it's just to inspire you to read outside of your own field as well. The Focus Manifesto is actually like kind of a bit like the OMI Manifesto. Every time, like, it's an internist, Larry Israel, who believes that everyone should be doing POCUS. It's the new stethoscope kind of, and he argues this, and he argues historically why we should change soon. And yeah, it's just great. Diagnosis, Interpreting the Shadow, another Patrick Crosby book for nerds. The Little Book of Loss and Grief by Liz Crow. Just a little bit cartoonish book, but amazing if you're sad, especially if you lost someone close to you. Compassionomics by these two guys, Stephen and Anthony, and they're, EM cases have made great podcasts about this. The Stimulus podcast have made great podcasts. I've made videos on this. Compassionate care is just so amazingly important in today's medicine, and it's probably not getting enough airtime. Trauma Room 2, like a small niche kind of essay story book by an emergency physician who goes by the pseudonym of Philip Allen Green. I think it's a pseudonym, yeah. And he's made another book as well. And they're just amazing short stories or essays about being an emergency physician, sitting in front of your stupid EMR or like just these tragic stories or the funny stories. And it's like I usually don't like reading about this because it's always like gore and stuff. Like it makes me think too much about work. But he's writing it with such a such compassion and such emotion that I actually enjoy reading this. And he's seeing it from the patient's side, and I really like this. Again, books for nerds, decision making. This is Scott Weingart's book that he sometimes refers to. It's hard to get nowadays, but it's there, and it talks about probabilistic thinking and so on. Decision making in emergency medicine, with a foreword by First 10 that you can read on his blog. I haven't read all of this, but there are several books of this, like these, which is going into cognitive biases, almost always they think biases are bad or something that you can kind of compete with. And yes, you do case reviews about where you can point out where the cognitive biases are. But that's the counter argument. Like the counter argument from Gary Klein is, well, we need, and from Justin Morgenstern, it has to be a balance between cognitive biases, right? Like some biases are really good. and some are we need them, right? And then we just have to know that they are there, and we don't know how to evidence-based. We don't know how to like mitigate the biases, but yeah, it's probably good to know that they're there, and these books can make you think about these biases as long as they won't paralyze you. I think the best book is the one that I showed you, the cognitive autopsy, in this kind of book line. I forgot another book, which is Catherine Montgomery's book called How Doctors Think, which is kind of a generic book term, but it's really deep and it's really good. And he talks about phronesis. And I forgot to podcast the recommended dose by the Cochrane Library. That was another one, but I forgot. Thanks for the feedback. And the Culture Code, I've already mentioned these books. For me, very inspiring books that have taught me a lot of the theories and hypotheses that I've heard around the FOMED culture as well. And like it may be like maybe a little bit of an echo chamber, but when you hear it from different sources, seems like more and more legitimate. Oftentimes. At least they're good reads, and lots of the theories I've heard from different independent sources as well are important ones. Sorry, the podcast I forgot before was the bedside rounds, which is this internal medicine guy in the United States who makes these historical, quite long podcasts about medicine, and he has some great podcasts. They kind of go around in circles and take the same topics again and again, but his podcast about epidemiology, his podcasts about diagnosis and the history of diagnosis is amazing as well. So worth taking a look at. I've referred it in some of the links as well. Chris Hadfield, always amazing to read outside of your own field. Again, this is an astronaut talking about exactly the same stuff that we sweat in a different way, and maybe more intense for astronauts. Maybe not in certain areas, but just amazing to hear someone say some of the same things that we actually need, and a lot of emergency physicians could benefit from reading these. I think even Cliff Reed in some of his lectures recommend the Culture Code, and Chris Hadfield's The Astronaut Guide to Life on Earth, and also this next one, Extreme Ownership by Jocko Willink, about leadership, and Cliff Reed is one of these Sydney Hems emergency physicians who has his own podcast and often is on MCRITS and other places because he makes amazing stuff as well. Also human, Caroline Elson is psychologist, talks about like who is a psychologist for just us doctors, and how we can teaches us how to be and how to comfort ourselves as well, and how to go beyond like she talks about our culture of like keep on working and all of this, and how we sometimes, like, I didn't know something called bleeper deaths, which is when you have such a long shift that you just die. It's apparently according to her term that's used. So this is more like an overview book of all of what we are, and as a general field of medicine, and how we can become better from a psychologist's standpoint. This is more the humorous side of this. Is almost like Scrubs or the House of God, like the modern House of God, I would say. This is going to hurt. Adam Kay. Same thing, but from a doctor's eye, a doctor/comedian's eyes. And just Matthew Walker's Why We Sleep. Kind of ironic. I never got through it, but I've heard several podcasts where he speaks, and then Andrew Davies on Mastering Intensive Care has talked a lot about this one, and seems like a good book as well. The Mindful Geek, just to throw in one of the mindfulness books. It doesn't have to be this exact one, but this is not about religion or anything. It's just a I guess Californian talking about how like mindfulness is important for anyone, right? Just a bit like cognitive behavioral therapy, I think, is also important for everyone. These like skills that we should try to harness.